We are joined by renowned infectious disease doctor, Dr. Michael Gow, and he is CEO and co-founder of Haven Diagnostics, and Mr. Ben Siegel, head of growth and operations for Haven Diagnostics. Dr. Gow and Mr. Siegel are joining us today to share their expertise and talk to us about the topic of today's discussion, COVID-19 in the workplace, understanding capital expenditures during a time of uncertainty. Before we get started, I would like to thank our sponsor for this session, Interstate Restoration. Interstate is a cornerstone partner of Bowman Greater Dallas, and we appreciate their support in sponsoring this event. Scott Gano, Director of Operations at Interstate, is here with us today. Thanks for joining us, Scott. I'm going to hand it over to Scott. He will tell you a little bit about himself and Interstate Restoration and then introduce the speaker. Welcome, Scott.
Thanks, Tim. I appreciate it. Good afternoon, everybody. Like Tim said, I'm Scott Gano, Director of Operations for Interstate Restoration here in DFW, and joined also by Jeremy Cooksey. He is one of our senior project directors in DFW. We're proud and grateful to be a cornerstone partner of Bowman Greater Dallas and for the opportunity to sponsor this engineering session. Interstate's getting your business back up and running so you don't have any loss of rent, income, or market share. What makes Interstate unique is we're a completely turnkey company, handling your job from pre-planning phase to the planning, mitigation, and emergency response, all the way through the construction and reconstruction efforts. Having a close working relationship with a disaster recovery partner like Interstate speeds up the process of getting your business back to business. Let us be your partner. Now, we're very excited to introduce today's speaker, Dr. Michael Gow, CEO, co-founder, and medical director of Haven Diagnostics. Dr. Michael Gow is considered one of the leading infectious disease doctors and applied artificial intelligence experts in the United States, specializing in agent-based modeling. His latest project, Haven Diagnostics, is solving employers and landlords' return to work needs from scientific analytic approaches. Originally developed to solve infectious disease outbreaks within hospitals, Dr. Gow realized there was an application for his agent-based modeling software beyond the four walls in healthcare facilities. In 2020, Haven pivoted to help employers communicate their workplaces in-office COVID-19 risk and infectious disease risk to employees. Haven's medical analytics platform measures and quantifies workplaces' COVID-19 risk around the world. Returning to the office can be difficult, and it's Haven's goal to help businesses make scientific and data-driven decisions. Dr. Gow and Michael Siegel are here with us today to share their knowledge and expertise and discuss how to understand capital expenditures in a time of uncertainty. If you have any questions for these guys throughout the presentation, type it in the chat box at the bottom of your screen, and we will get to them at the end. Everybody, welcome Dr. Gow and Michael Siegel. I'll hand it over to you guys.
Well, thank you, Scott, and thank you, Tim, for the introduction. It makes, when I hear the intro, it makes me realize how much of a nerd I am. So absolutely appreciate the time to talk to all of you. I'll share just a handful of slides, but wanted to reserve probably at least half of the presentation for just more of a back and forth conversation and discussion with the group to get a better understanding of many of the challenges and questions that that you're facing. As Scott mentioned in the intro, we work with a decent number of landlords, but also a decent number of occupiers to have some understanding, even outside of the science, from their perspective, how they're thinking about office safety and office reentry, which is, of course, something we want to help all of our tenants and customers do. And so just a little bit about us. I was previously the medical director overseeing AI at New York Presbyterian Hospital, focusing on hospital operations. My co-founder for Haven, Josh Galeris, is funded by the NIH and the Department of Defense for COVID-19 research. And we're both practicing physicians as well. So I do think that we bring a relatively unique perspective because it's not just about the research, but it's really about the application as well. So combining research, operations, and clinical care. And in some ways, I think because it's about the application, we try to espouse what we think of as a very pragmatic view, which is that there's only a few countries in the world that are authoritarian enough to confine people into their homes for an entire year. I don't think any of us wants to live in any of those countries. And so the solution then is, how do we educate people on risk? And how do we help people identify activities that they can do and areas that they can go to that are actually lower risk? So preserving both sort of the function and the needs of society, as well as giving people informed information on what they can do. And that's actually, the main point of the presentation, which is, I think there's a large portion of society that are thinking about the disease from really what we think of as a binary or a black and white mindset, which is, if I'm home, I'm safe, and if I go outside, I'm in danger. But the reality is that not all environments actually are equal, and that the office environment can be one of the lowest risk environments. The other thing I'll mention here is, when I say lower risk, a lot of people think, okay, great, this is a little bit safer, maybe 20% safer or 30% safer. In other words, it's a little bit safer, but it's fundamentally the same thing. The reality is that compared to some environments, restaurants as an example, if you think about it, offices are usually staffed with people who are, professional and working age, and therefore living with a nuclear family, driving to work. There can be policies and procedures enacted in the office, and it's in a building with professional management capable of maintaining a relatively clean environment. And so when you add up all of these different factors, what we find is that it's not just a little bit of difference. It's actually a dramatic difference, not 20%, but more like 20x. And by the way, this is not just something that we've modeled or something that's just theoretical. When you look at states and countries that have done enough contact tracing to release where viral transmission has happened, this is supported in that data as well. And so what doesn't completely make sense to us is that despite the fact that the office is 20x lower risk than other areas, I think when we look across our society, it's actually one of the least populated, so perhaps one of the more restricted and more locked down environments. And when we talk with employees at our tenants, there are, or at our customers, there are always 26-year-olds who are going to friends' houses or going to restaurants at night, but then the next day telling their employers that they're afraid of going into the office in the morning. And so that, to me, doesn't match the data. And so I think there is an opportunity to arm employers with data that helps them say, hey, certainly if you're 68 with medical conditions, you should not be in the office, and we're not going to absolutely force anybody back in. However, here is data showing that for many employees, the office can be a low risk environment. So We're fortunate, I think, today to be in a position where almost a year into the disease, we know more about how COVID spreads. But it wasn't always this way. And there were some early misconceptions about the disease that have persisted despite, sort of better knowledge. So this is a scary picture, but I remember very vividly back in March and April when the streets of New York City were completely empty, and every single patient on my list in the hospital was a COVID-19 patient. And what was interesting was that the steady drip of patients that I would normally see with heart attacks, strokes, kidney infections, all completely vanished. People were terrified. And every patient who came in had COVID-19. And at that time, not only were we not sure what the mortality rate was, but because testing was so limited, we also weren't sure how contagious it was. And so, conceptually, there's a huge difference between viruses that can survive on surfaces for days or hang suspended in the air for hours, and viruses that cannot. So measles, as an example, is a virus that's extremely infectious, and where COVID might have an R0 of 2.4 or 2.5, measles is actually approximately 7 or 8 times more infectious. And so at that time, if this virus was something that was, really 10% lethal and every surface would be contaminated for days, then really, if you think about it, the only viable way of preventing hundreds of millions of deaths would be just total absolute lockdown. But then, there's some early data that was pretty interesting, which was that when we saw super spreading events, what we saw was that they were concentrated in a few different venues. So bars and restaurants, call centers, meat packing plants, choirs were all examples that many of us saw several times. And conversely, there were lots of places where people consistently gathered, but where no spread was seen. And so, of course, one of these is outside. And I remember even places with super spreading events that could be outside, like ski resorts, it turns out when you look more into the data, the spread actually happened within the bar that was sitting in the ski resort, rather than, the line to go up the mountain. And movie theaters was interesting because that's indoors, right? With lots of people packed really closely together. And if you think about it, this difference between some places got a lot of spread and some places didn't get much spread is inconsistent with the virus living on surfaces for, in the prior slide, 28 days at a time. If it was really true that the virus was that contagious, then you should identify super spreading events across all different environments. And what we quickly saw was that this was true in the hospital as well. So across hospitals, across the country, we've seen transmission in some areas that you would expect. For example, emergency department wait rooms, or staff break rooms where people are maybe letting down their guard and where they're in close proximity and speaking with others. But what was really vivid was at the time, even though we had physicians who contracted the disease from patients, there was a conspicuous absence of spread in physician offices. And so keep in mind, this is New York City. So there's 3 or 4 physicians sharing an office, hot desking, sort of collaborating together on patients, and still no spread in that setting, which is really interesting. So since then, we've gathered a lot more data and we've started to understand why this phenomenon is the case. And so the first piece of data is actually, pretty commonsensical, which is, as you expect, and as we all know now, respiratory viruses transmit primarily on the basis of droplets and aerosols, and much less commonly on surfaces. So the initial research showing that COVID-19 could only survive on surfaces for a very long time only ever tested the genetic material of the virus and not live virus itself. So not to be too gruesome, but at a murder scene, right, and I've never been to one, but in TV shows, you can find the DNA material of the victim at the scene, but just because the genetic material is there does not mean the person is still at the scene. And this, by the way, is, for a relatively obvious example, which is, for security reasons, only a handful of laboratories in the US can grow live virus for dangerous viruses like COVID-19 to test whether they're able to reproduce or not reproduce. And so we've also done studies on the amount of aerosols and droplets released by people doing different activities. And it turns out that, as you expect, that's not the same from activity to activity. And so since droplets and aerosols are just a fancy sort of medical way of saying the word spittle, I think it comes as no surprise that people who are speaking generate 30-fold more aerosols and droplets than people who are sitting still and breathing. And that explains why it's the case that in movie theaters where it's packed with people, but more importantly, packed with people who are being really quiet, were not a major source of spread. And weddings and choirs, even though you don't go to that many weddings per year, and most of us don't sing in choirs, are relatively rare activities that were actually pretty frequently a source of spread. And so we'll talk more about this later on, but when the people in this room are thinking of, MERV filtration, are thinking of air changes per hour, are thinking of ionization and where to apply those technologies, clearly applying those in areas where more aerosols and droplets are generated have a larger absolute effect, because even you may be decreasing the overall amount in the air by 70%, but if you're starting from a really large amount, that has a much greater impact than if you're applying it in an area that's already quite clean. And this, by the way, explains a lot of the fundamental difference between offices and restaurants, which have, depending on the restaurant and where you are, potentially not too dissimilar density. But in the office environment, workers are much more quiet. People are sitting at their desks typing away. In the restaurant environment, people are conversing and talking a lot more loudly. By the way, here, one thing that's really been interesting is we don't have enough data to say this with a high degree of certainty, but it seems possible that
¿Qué dijo?
it seems, sorry about that. It seems possible that in restaurants that play background music and loud background music that cause people to talk more loudly, that actually those restaurants see a higher rate of transmission than, say, fine dining restaurants where it's more quiet overall. So what's funny is that applies literally to things as as seemingly mundane as whether you play elevator music as people are going up the elevators within your office building. And then what's really interesting is that what we've learned is that with the flu, as an example, lower dose of exposure doesn't just mean that you're less likely to get it. It also correlates to the severity of the disease itself. So this was back in the day when researchers could, this was before medical ethics were a thing, and researchers could do kind of whatever experiment they wanted. And so for the flu, they literally took people and sprayed volunteers with different doses of the virus. And people who were given a more concentrated spray were not only much more likely to develop the flu, but also develop things like, pneumonia. Whereas people with a mildly concentrated spray were often quite asymptomatic. And so, of course, this is not something that we can do with COVID, but this dose-related response to severity is potentially something that we have seen with COVID as well. So early in the course of disease, we had colleagues who were exposed to a massive dose of the virus because nobody knew that the virus was even in New York. And despite being young and healthy, some of them did really poorly and ended up in the ICU or worse. So, one example was I had a colleague who was a surgeon doing a procedure. And when you're doing procedures, you're often aerosolizing a lot of fluids just in the course of the procedure and inhaling a bunch of them. Later in the course of disease, we still had physicians who converted, meaning they went from, not antibody negative to antibody positive, indicating that their immune system was exposed to the virus and fought it off. But with the appropriate measures in place, the number of people who had to be hospitalized or worse was dramatically lower. And so in terms of identifying low risk areas and low risk activities and interventions, it both reduces transmission and potentially reduces severity. But I think one question that we face or that we've heard from some of our customers is, why is it important to think about this in a more sophisticated way? Should I not just completely wait until the vaccine is here and we reach herd immunity and everybody is okay? Well, I think what we would argue is that when we were back in March or April of 2020, that we thought, okay, by the summer, this will all go away and everything will be okay. In the summer, when there was still a little bit of virus, I think we thought after Labor Day, this would all go away and we can just go from 0 to 100. And then it was New Year's, and then it was maybe by Q2, everybody will be vaccinated. And now, of course, we're seeing in the news, maybe not enough people will be vaccinated until Q3 or Q4. And even I would submit, every year about 46% of people get the flu vaccine, and we need probably 80% of people to be vaccinated to get herd immunity. So, will we ever reach 80% vaccination? And, when will we reach herd immunity? I think these are still unanswered questions. So what we advocate to a lot of the employers that we work with is just waiting forever and hoping that the problem solves itself is, really not a strategy. And if you're paying rent on your office for 1 year, for 2 years with it, really not being used, that's probably, not what is necessary for most businesses. And so that being said, I think there is some good news I should note, which is that the vaccine, just like exposure to the disease, is not an all or nothing phenomenon. So even if 30 or 40% of the population gets immunized from the vaccine, what we still expect is for it to be much more difficult for the virus to transmit. And for these large peaks, like what we're seeing this winter in many parts of the country, to be, significantly less likely. And so that's a long-winded way of saying, based on the current knowledge and what we know about low, medium, and high-risk environments, we do think that employers working with their property management team, working with HR and their employees can remain open and remain functional. And it's actually not a novel proposition. And so I think one thing that's always been interesting, for people to hear is that not everywhere, but the rates of COVID in nurses and physicians are actually not that different from the rates of COVID in the general population. And so I should note that it's not because all nurses and physicians are wearing hazmat suits, all day long and not having any exposure at work. In fact, people almost always take off nearly everything except for face masks when they're at their workstation. And of course, there's the commute here in New York from home to your workplace. So I see that as evidence that it's possible to craft sets of policies and procedures that allow work and communication to get done without jeopardizing people's health. And so taking a step back, certainly I think there's some different frameworks that we can apply for COVID-19 transmission and what causes it. So one way to think about it is really thinking about aerosol, droplet, and contact, which is, I think, the framework and how we divide it and how you hear about that in the news. But another is thinking more about indirect risks versus direct risks. So an indirect risk based off this classification is when a person gets COVID-19 from the environment. This is something where you as a person are doing everything right, but you walk into a room somebody was in earlier, or something comes through the vent, quote unquote, and that's how you get exposed to COVID and how you become infected. Then there's direct risks, which are, say Scott and I are having a face-to-face conversation, and the virus is essentially transmitted directly from myself to Scott or vice versa. The way that I would frame this is that I think what people are most scared about when we speak with employees at many of these companies is in some way the indirect risk, which is to say, even though more transmission occurs by direct risk, it's the risk of things that you can't control that are the most scary. There's more people with a fear of flying than a fear of driving, even though driving results in, even on a per mile basis, many more accidents and many more deaths every year. And so what's neat and what's empowering, I think, is that this indirect risk where, COVID is going through vents, I'm afraid of, contracting COVID from surfaces. Those are things that are under the, or at least can be communicated and can be impacted by the landlord and the property manager. And so there's, of course, for, different people, different right actions and different amounts of capital that can be deployed. Most landlords can take simple, at least some simple and effective actions that reduce transmission risk. And I'm sure the vast majority of you are doing all of these already, at least, as far as your air handling units can support. And so mask policies, of course, impact building staff who are interacting with multiple sets of tenants. And then density limitations in common areas like gyms and shared meeting spaces are really critical as well. And given that it is an airborne virus, and given that the amount of aerosol and droplet in the air correlate with the probability of transmission, as well as with the severity of the disease, ventilating your room by increasing air circulation, by improving outside air intake rates, are highly effective at reducing the risk. The things that I would caution against in terms of an investment standpoint, well, perhaps caution against is too strong. The things that have potentially helped psychological safety, but have lower ROI are things like, cleaning every possible surface several times a week. I think extra cleaning is perhaps warranted for common touch areas like elevator buttons and certain door handles, but trying to do so broadly across your lobby is probably not going to change the probability of transmission, and it can cost a good amount depending on your setup. And then I think conversely for tenants, and we've communicated this with tenants that we've been working with directly, the risk of transmission in an elevator or, as they're walking through the lobby, especially if people are wearing masks and not talking, can actually be quite low. It's a few seconds to a few minutes of exposure. And I think especially when you add that, when you add on top of that, all of the different things that many landlords and property managers have done to further decrease risk, the overall risk of sort of shared spaces is quite tiny. And so taken together, that's these are real numbers from a real client, by the way. So what we found is that the annualized risk of disease transmission from, going to a bar once a week or going to a restaurant once a week is somewhere in the 5 to 15% range. But that going to a corporate office, including walking through the shared spaces of the building, going up the elevator, and being in the office, not just 1 hour a week, but 8 hours a day, can still be, despite that much more time in the office, somewhere on the order of 5x lower, depending on the setup, than those comparable activities. So going back to that original point, it's not just that the office is 20% lower risk or 30% lower risk. It's that with everything that you guys are doing and with the policies and procedures in place, and of course with good personally responsible behavior, risk can be decreased 20x or 30x on a per hour basis. And then, of course, what I would say is that it's not a one-step process. And I think what's been challenging for many of us is that we may be, more educated, and we may have a good grasp on everything that's done for the building and for the workspace. And I think what's really challenging is that it doesn't change company sentiment until the employees themselves working at that company begin to have a grasp of these concepts. And so we've, I think we've worked with tenants where the head of commercial real estate, as an example, says, yeah, I'm on board. I know what the landlord has done. I know what the engineering in the building has done. But now me as a corporate real estate person, I'm trying to communicate this to the rest of senior leadership I'm trying to communicate this to my employees, and I don't have the data and I don't have the right words to use to make that communication effective. And so in the cases where we have seen that internal communication be disseminated the right way, we have seen occupancy go from the 5 to 10% range that I think many of us see with large tenants to somewhere closer to 30 to 40%. And by the way, without mandating, return for the office as a whole. So it's about, of course, making sure that that understanding is adequately communicated and that the executives of the tenants are appropriately aligned. It's about them feeling good about their safety policies, and then in conjunction, the landlord and the employer working together to make their employees feel comfortable. And then finally, the result of that is that occupancy increases. The other interesting thing I will add as we there's these key takeaways, which I think derive pretty clearly from the content of the presentation. But the other key point I would add is, over the past 20 years, we'd like to say that COVID-19 is a once in a century pandemic. The reason why some of the Asian countries, Korea, Taiwan, parts of China, Japan, were so prepared for COVID-19 is, of course, because this is not the first time they've been hit by SARS. And so, between SARS, MERS, bird flu, swine flu, a lot of work that I think many of you are investing in your buildings are what we think of as no regret decisions. And I don't know that there's a clear sort of, a clearly delineated market demand for this today. I think everybody is still finding their footing. But when we've spoken with our tenants, we've had their, heads of HR or their chief risk officers say, we want to feel good, not just about COVID-19, but about future preparedness as well, both for employee comfort and for decreasing operational risk. So we do think at a high level that, the work that many of you are doing to make your buildings a lower risk area will carry forward and be great investments for the future. So I wanted to take, I guess, the remaining of the hour just to maybe have more of a dialogue or better understand the questions and challenges that the people on this call have been facing. But either way, really appreciate the chance to communicate some of our findings and some of our work to this audience, and hope everybody here found it useful as well.
Dr. Dow, this is Tim. I have a question. So I've done some research on bipolar ionization and a couple other things. And, one of their sales pitch is, well, if you put these in, you can decrease the outside air going into the building, and, then
Right.
you'll have a payback in energy savings. Is that something you would recommend doing?
Yeah, I think it's a really good question. I would break things down into a couple phases. All of you will be more familiar on this subject than me, but in any given building, given the outside temperature and outside humidity, there's kind of a maximum amount of outside air that you can take in while still having, somewhat reasonable energy costs. And so I do think that bipolar ionization, electrostatic technology, UVC lighting, I do think that those technologies probably work. Again, in the absence of really robust studies in high security labs, it's impossible to be 100% sure. But given what I've read on the literature, I do think they work. And what that allows you to do is it allows you to have, the way I would think about it is a higher degree of effective air exchange, where you have the clean air from the outside that you're taking in, and of course the internal air that's recirculating, and then the total volume of both is greater than what you could have achieved with outside air alone. I think that's probably the stronger communication point with tenants right now. In the future, though, I do think that, as all of you have to worry about energy efficiency, one thing that we've been working with some landlords on is to try to calculate what their effective air changes per hour should be. And then they can decide how much of that should be outside air and how much of it should be, with some of these newer technologies like DFS or bipolar ionization.
Dr. Gao, this is Joe Garcia. What third-party testing has been done with UVC and ionization? And has there been studies where there's been long-term effects on people feeling sick or having an effect on the ionization or UV?
Yeah. By the way, everybody here can call me Michael. No need for the formality. So the most of the literature on UVC and on bipolar ionization has been done with coronaviruses that are not specifically COVID-19. And so, these are coronaviruses that are, by the way, the common cold is a type of coronavirus. So the vast majority of the family of coronaviruses is something that causes extremely mild disease or does not cause disease in general. When you look at the studies, so for instance, UVC studies, there has been at least one UVC study that's done on COVID-19. The way they do it is they hold the source of the UVC over a plate of virus, and then they expose it to a certain amount, and based on the millijoules per square inch that gets exposed, they then measure the before and after degradation. The biggest challenge I think that engineers face as they're working with different vendors is a question of is the amount of UVC that I'm actually using comparable to those studies. And so in the only study I know of that uses live coronavirus, they held the UVC diode over COVID-19 for 30 minutes. And then they found a 99.9% decrease in COVID-19. But of course, in your ventilation systems, the virus is blowing through much more quickly. So you can counter that with higher voltage. You can counter that by making sure that there's multiple UVC tubes and things like that. But that's where it becomes tricky to translate those studies to the exact kill rate seeing in your systems, and something where you as the engineer would want to make sure that the sort of level of exposure between the two can be similar. In terms of harms to people, what I would say is the challenge with bipolar ionization is that it potentially releases ozone. Ozone has a lot of free radicals, which over time and with large quantities of exposure can potentially cause harm, and then in lower quantities mostly just cause a little bit of irritation. I think there's at least some manufacturers, and I don't have them off the top of my head, which have done testing to make sure that with the ionization of the air, no significant ozone is produced. With UVC, what I would say is if you place it in your ducts, where nobody can see it, and there's sort of adequate protection for the person who has to change the lights, there's relatively little harm. the UVC posts that are in common areas, or where some of that reflected light could be exposed to individuals, I think that's a little bit tough for us to recommend. And the reason is just that, does UVC in the 223 nanometer range, does it penetrate deeply? No. Can you guarantee that none of the, customers walking through your space, none of them have a scratch in their cornea? Can you guarantee that the manufacturer was so good that it releases UVC light in 223, but not 224 or 225? I think that's pretty hard to guarantee. So for avoiding the harms of UVC, we generally sort of think more highly of the ones that are installed sort of in the duct and air handling unit systems.
I have a question about the distances and installing the UVC and the bipolar. If you have local air handlers on that floor, it seems like the intensity would be greater. But if you have stories or feet to where you can install the air handlers or the bipolar in the penthouse, saying to get enough concentration to that second and third floor, will that still be beneficial?
Sorry, in this case, is the bipolar or ionization installed in the room itself rather than in the system? Or do you mean that it's installed in the supply or return vents of those floors specifically?
No, it would be supplied per se on the 15th floor in the main built-up air handler system, and we have one per building. Can I get enough concentration to those lower floors to be effective?
Got it. Yeah. So the way I would model this is that if, again, assuming that the intensity and the duration of exposure is enough, then the air that gets recirculated from that air handling unit is, I guess, what I would consider clean air. And when the clean air enters whatever room it goes to, whether that's in the first floor or the 15th floor, it will displace any or dilute any air that has aerosols or droplets in it, thus decreasing the risk of infection. However, what I would say is certainly for UVC, I know you're not saying this, but there's no UVC that's contained within the air that then goes through a room and kills the virus sort of from a distance in that room, if that makes sense. So you're pumping in clean air in which any virus has been killed. You're not pumping in the UVC or a significant amount of ionization itself.
So this is Tim again. I've got a question on the chat. Are there any good resources that you would recommend on any studies on UVC, bipolar ionization, et cetera, that you would recommend?
Yeah, we can certainly send our list of studies, to I presume we can send it to you, and then you can forward it to the group thereafter. We can certainly send the studies that we are aware of. I do have to say that for both UVC and bipolar ionization, it makes sense from a mechanistic standpoint. It's been proven with a lot of, UVC more so than bipolar, which is a little bit newer, have been proven with other types of viruses and microbes. And so there's nothing about coronavirus that makes it totally different from any other, virus or microbe, and I would expect it to work as well. There's very few studies in which they've grown COVID-19 in a lab, and then, we're able to look for live virus before or after some of these effects, and fewer still where they're able to release it in the air and test it in sort of a real life environment. There's, I think, about a dozen labs across the United States that are BSL-4, which is a level of security clearance that's required to test dangerous pathogens. And for I guess obvious reasons, they're mostly focused on sort of biodefense and other applications. So it is something where we're applying our knowledge of other diseases to COVID. There's at least one good paper on COVID-19 and UVC. So we'll send a collection of studies for those to the group.
Sounds good. Anyone else have any more questions? Okay, well, I guess that wraps it up. Thanks, Michael. We appreciate your time, and thanks again to Scott and Interstate Restoration for sponsoring the event. If you guys have any questions, feel free to email them to me, and I can forward them along and see if I can get them answered in the future. But thanks everyone for joining us today.
Great. Thank you, Tim, and thank you, Scott. Take care.
Thank you, guys.
Bye.